started then. So
Okay.
I'd like to welcome everybody once again to Inside the Doctor's Lounge, a place where we can all come together, have honest, frank discussion on any number of topics. It's kind of like what happens inside a real doctor's lounge. And today, besides our usual crew, Rhonda Crow, CEO and founder of MD Coaches, Rick Zollinger, and Randy Cook, I am especially honored and privileged to have a dear friend and colleague, Dr. David Armstrong, coming by way of University of Southern California and Keck Medical Center there. So
yes,
if you haven't met Dr. Armstrong, you're in for a real treat. David is truly a giant in our field of podiatry, but more importantly, the specialty of wound care and limb preservation. And so with that in mind, I figured today would be a good time to talk about not only the diabetic epidemic that is going on. And, you know, we've talked about pandemic, obviously, through this crazy year of 2020. There's been a pandemic that most people probably don't even realize has been going on for quite some time. And that is the explosion of diabetes. It's not just here in the United States that this is occurring. It's worldwide. It's a worldwide phenomenon. And the things that occur with diabetes are often not recognized, not appreciated. And so today's a real important topic that we're going to discuss, and some of the things about what it's like to live with diabetes, what it's like treating patients with diabetes. Interestingly, all of us regulars here have all had our role in wound care for a number of years too. So David, welcome. It's great to have you here. And, you know, you're just going to see, we're going to talk about anything. This is just going to kind of take on its own form, but can't thank you enough because I know you're a busy guy.
Des Bell, man, thanks for having me. Thank you for letting me play hooky from what has been a crazy day already. And a stream of consciousness, that's right up my personal alley. We'll,
yes.
We can take it whichever way you want, kind of like a Flaubert kind of novel or like a Madame Bovary kind of thing. I'm not much of a Francophile, but if you want to go there, we can.
We can go to hang gliding for Southern California.
We could indeed. We could do whatever you like.
Listen,
we can glide into whatever you like.
I'm going to tee this up because I have a couple of questions I want to throw out there that maybe for our audience really to kind of get a better perspective. But, you know, you and I have been, you know, again, share the podiatric perspective. And I know personally, there have been several moments in my career that were sort of defining moments that really kind of made me aware of the path that I needed to follow. You know, not only that would make me happy personally, but I saw the importance and the need. And that really, in a nutshell, is what limb preservation is to me. Wound care, limb preservation. Like I said, I've had several instances, and I'll share those. But I just wanted to ask you, was there a particular moment or a specific incident? Because, you know, your dad was obviously a podiatrist. Many people may not be aware of that, and of really high stature in our community. But was there something that triggered this, this passion that you display on a daily basis?
So there were any number of kind of events, but there were ones that I kind of call back on and remember. As you know, Des, I grew up in my pop's office and sweeping up and making orthotics for people and bringing computers in there for the first time when it was super exotic in the 80s. I remember that. It was like, what is this wizardry? And now, of course, God, I would just want to rip the computers out if I were in the office now. Just get those electronic medical records out of there. But for a handwritten chart now and a real note. My God. So I may have talked to Randy about this when we chatted. If I'm not mistaken, I remember, and I was just recalling it when I think I spoke to Randy about it. And Randy, you can stop me if I'm repeating myself, but I hadn't thought about it in forever until I talked about it then. But I was my first, I think it was my first day or second day as a surgical resident, and I was in Detroit. And my first day, I was working in the operating room, or Des for you, because your first name's Desmond. It sounds very British. The operating theater, to kind of translate for our folks. I was in theater, and I had just done this case with one of my mentors, this guy, Guy Pupp. What a great guy, still alive, unbelievable, hard to kill, Guy Pupp. But one of my great mentors, and just a terrific, superb teacher at surgeon. And it was on, and I'm not violating HIPAA, I assure you, but it was on this a competitive basketball player, college player. And it's like 6'9" character. And I think I put a screw in this fella. Or lady, we'll just for HIPAA, I remember it was so testosterone inducing, it was great. But after that, and things looked great post-operatively, and then patient spent the night, and the next day I brought him over to the clinic. I wheeled him over across this frozen tundra, even in the middle of the summer. I still remember as it being frozen tundra in Detroit, into the clinic, and to take off his cast or put him into a new one and get him out on his way. And so I did that, and I was getting him in the room. And as I was doing that, there was some delay like usual. And right next door is this little lady, because I figured I'd help in clinic. Why not? There's this lady, maybe 4'9", and she tops. And it turns out, as I'm working her up, she was there with a diabetic foot ulcer. She had just come in from India, and she had her whole family in this little room. And forgive me, by the way, I'm just remembering this all as it happens. And as I'm talking to her, I'm looking at this ulcer, this wound on her foot, and she's kind of bleeding on the floor. And I'm already thinking there's just something doesn't feel right already. And I look at her hand, and her hand is kind of burnt a little bit. And so I work her up a little more, and she had leprosy. She was in remission from leprosy as well as diabetes. So both things that cause loss of feeling. And I said, well, how'd you burn your hand? She said, oh, well, when I just got in yesterday, literally just yesterday from Chennai, I was cooking naan bread for my family. And, this is through her son who was translating. And I flipped the bread over in the oven, because I'm a baker back at home in Chennai. And so as I'm doing this, I'm trimming her wound, and she's kind of bleeding on the floor. I kind of take a step back. I go, what the heck? She like burned her fingers off. And I step back, and there's these two rooms. The one room where is this 6'9" big Adonis guy, just out of surgery, writhing in pain. A great guy, by the way, who's writhing in pain, as he should be, post-operatively. And then right next door is this little lady, maybe 4'9", bleeding on the floor after I basically just trimmed, divided her wound, and her hands burned off from baking. And I'm saying, eeny, meeny, miny, mo, we're all trained to treat pain, and we're conditioned to respond to pain. As human beings, we respond to pain and to accidents and emergencies. But what we don't respond to is the absence of it. And so I'm thinking like, wow, treating pain or treating the absence of it. No one's doing that. A lot of people are doing this. So that was my first day as a resident. And so to make a short story long, there you go, Des Bell. That was it. That was the first day of the rest of my professional life.
Yeah. It's interesting. I found similar type thing. I found early on, while I enjoyed doing the orthopedic stuff, because that was what really drew me to podiatry in the first place. I was going to go the ortho route anyway, and there's a long backstory there, but I wanted to do sports medicine and work with athletes. And yet I found myself being more and more drawn to this, where I saw this need, and it just blew me away. And I think watching what patients, not only patients would go through over time, but also their caregivers and their loved ones. And I saw this parallel with watching cancer patients. Mm-hmm. I lost a sister to Hodgkin's disease many years ago, and it brought back a lot of emotions and memories of going through that experience and what it did to my family, like constant trips to doctor's offices, waiting, waiting for good results, not knowing what was going to happen next, and all these things. And I saw the very same thing happening with our limb preservation patients, those people dealing with diabetic foot ulcers or chronic wounds. And so it had such an impact on me. It's like, no, this is where I need to be. And so interesting that you kind of had a similar thing, and dealing with a patient of all things with leprosy, which many people they probably don't realize that leprosy it's still out there, even here in the U.S.
Yeah. Des Bell, a little thing. I'll give you a little bit of trivia. We have at Keck at USC at LA County, my good friend Maria Teresa Ochoa. But she sounds like a nun, doesn't she? Maria Teresa Ochoa. What kind of that? She's got to be like that. Anyway, but MTO, as we call her, is a really renowned dermatologist, and she runs the largest leprosy clinic in North America now at LA County. And we're kind of creating a liaison. We have a number of patients that we share. In fact, I just did a reconstruction last week on one. What a great lady as well. Reminded me in some ways of the one lady I just told you about. But she had a Charcot and we reconstructed the foot. But anyway, the point is all of the things that you bring to bear, Des, in this dinky little specialty in kind of limb preservation, working at the end of the body, you can bring all of the reconstructive creativity to bear on tissue repair and wound healing, as well as everything else, to try to get people and help people kind of move through the world a little better. And that's really the goal, isn't it? I mean, it's just so they can kind of navigate their world a little bit better, we sort of help them along. And,
exactly.
Well, there you are.
I always felt like I kind of felt like sort of like a little bit of a tour guide myself. We're trying to help them, regain certain independence, get their life back as best we can help them get there, and then move forward too. Yeah, you mentioned a word earlier too, David. Talking about remission of her Hansen's or her leprosy. And so, one of the terms that you've brought out when discussing diabetic foot ulcers is this concept of remission. A lot of people don't understand, what that diabetic foot ulcer really represents. And to us here on our panel, we all get it. That is not only the pathway to amputation, but you've been such an important driving force of this message that it's really a marker for a lot of other things. 5-year mortality rates, as we know, are really bleak compared to other forms of cancers. But, it's that concept too of remission. When we get that diabetic foot ulcer healed, is it really healed or are we in remission? So I want you to just talk a little bit on that.
Sure. Well, it's funny. I just thought about this now that we're in the doctor's lounge, and one of my strongest memories as a kid was being in the doctor's lounge with my pop. And it was this very subject. Let me tell you, Ed, I don't know if my pop passed away about 15 years ago, but I don't know if the other characters in this drama did. But I had just gotten out of a surgery with my dad, and I had just done a triple arthrodesis. My dad did. And I said, oh my God, this is like the greatest thing ever. And I was like a second-year student. I didn't even know one end of the freaking thing from the other, but I got to do a little bit. And I thought, boy, oof, I'm like, it was really chest thumping. And so I'm sitting there, with the scrubs on, and I got my mask kind of halfway down, appropriate position and everything. I'm just kind of sitting in there decompressing with my pop, and my pop's in there with his friend and our family friend, a guy named Dave Book. Dave Book and Marge Elfring were two orthopedists in our town. I kind of grew up with, and my dad kind of sees me sort of kind of gloating or something or other, or being kind of hubristic. I don't know what he saw. He just saw a big head or a head getting bigger somehow. And I think, and he looked over at Dave Book and he said, Dave, because Dave was looking at the x-ray, we were talking about the case. And he said, God, I'll take 20 ingrown toenails for every one of these cases. and I'm thinking to my dad, what the hell? Well, don't, that's crazy. How could you possibly do that? Dave Book doesn't even understand that. You're just belittling this whole specialty of yours to Dave, who's like this bone doctor. What the heck? And Dave Book kind of smiles and says, I understand what you mean. Because Dave says, what he said at the time was that, you do one of these cases and you're married to Ms. Garcia for the rest of her life. And,
that's right.
And, at the time, that kind of discussion in the doctor's lounge, for me, I was like just a little kid, was really impactful. But it was, I kind of, over a long period of time, it's sort of flipped on its head because now I sort of do the opposite because I am married to those patients and like we all are, because what I know now, what I didn't know then was, first of all, sometimes the best surgery is the one you never did, God knows. And the other thing is, nothing ruins a good surgery like follow-up, right? And doesn't matter what you do. Follow-up will, every repair is going to go down eventually, unless your patient goes down before that repair goes down. And so maybe a little more humility rather than hubris as we try to teach our residents and fellows and trainees when you're at the end of the body. But can we really fix anyone, or is really our goal just to help, as you said, Des, kind of help folks move through the world a little bit better? And to that end, just as you said, we've done a lot of work in the area over a lot of years. So many, you for sure, God knows, have led the way in this, but, studies that we've done have shown that after, with the best available data, after you heal someone with a diabetic foot ulcer, about 40% are going to have another ulcer in the next year, about 2/3 in 3 years, and about, give or take, 3/4 in 5 years. So recurrence is not only common in this population, even with the best available therapies. And there are a lot of therapies that are improving this, but recurrence is likely. So maybe we shouldn't say that we heal anyone, right? And so maybe we ought to change, maybe we ought to change the dialogue so that that's why we use that term remission.
Two things that came to my head when you said that. One was Dr. Ochsner saying to me when I was finishing training 30 years ago,
wow,
you can operate on everybody 100% of the time, but a good surgeon doesn't.
Yeah.
That's your answer to that. But these guys have heard me say before, when you talk about the diabetics and the wound care, which I came into late, the eye opener for me, and they've heard the story of the patient I had that comes in riding their go-kart, comes in, their legs are this big, they've got diabetes, ulcers, they go to dialysis, Of course, I walked in and said, I'm going to fix this and cure it, because that was my mentality from where I came. And that patient, to that day, I went back and I was standing in the shower and I went, hey, you dummy, you don't put yourself, you need to negotiate. You need to listen to his life, so you're right. They're your patient forever, but you have to learn to put yourselves in their shoes. And one of the things I wrote about just recently, I said, well, as a physician, we'll come in and say, this is my goal. We're going to heal this ulcer and you're going to do wonderful. And that's going to be what it is. But we never walk in and say, what is the patient's expectations? Mm-hmm. Maybe that's not it. Maybe he just wants to walk,
right?
Or go to church without having a cast on all the time. I mean, who knows?
This is part of a concept too. This is part of our job, being patient advocates too. Mm-hmm. That's what advocacy really is. Part of what advocacy is putting yourself in their position and trying to not only have empathy, but trying to understand too, and not just just force your will on them or what you think, the guidelines tell you are the best. You've got to kind of process all this stuff. And like we said, you're going to guide them through this process. And that's, give them a voice. You have to.
Well, Des, I mean, that's it. I mean, there's it's, you're doing something, we always say to our patients, we want to be doing, and this sounds like it should be on a poster, kind of ridiculous or eye rolling, but I assure you, we talk to our patients about this all the time, and it's not. We say, Mr. Jones, Ms. Smith, we want to be doing something not to you, but with you, and it's when folks hear that, They know you're not. I mean, they're going to know if you're just dialing it in, or they're going to know if you're for real. They figure that out right away, even on a busy day, when everything's falling apart and no one's doing well, and you're getting supposed to be in the OR because they're calling you down there for that. That is sacred, and it's way more important than anything. Although technique is critical as well, and you got to be, but that supersedes everything technical. That's
agree.
The most important thing.
To me, that's like the difference between being a good doc and a great doctor. It's putting all that together. It's the whole package, and you can't. It's not cliched at all. There's a reason that these little so-called cliches are out there, because there's a lot of wisdom in there. And if you adhere to that, or really have an open mind and try applying some of those little things, it really does make a huch difference. So,
and Des,
Randy, I didn't mean to cut you off, Randy.
No. There's no cutting me. But there, one thing that I would like to do is add something of perspective. I hope. I'm not sure exactly where we stand on this, but I think I'm the guy who's been practicing medicine the longest here. And I often reflect on the fact that when I was in medical school, when I look back on it, it was just amazing to me how rare it was to see anybody in the hospital, for sure, with complications of diabetes. In fact, we didn't even know what type 2 diabetes was. We were just beginning to see this thing that back in those days we called adult onset diabetes, which turned out to be a completely different disease from the people with inability to make insulin. And it has turned into you want to talk about pandemics? We got a completely preventable pandemic on our hands. And it just continues to get worse. This is a completely preventable disease.
Randy,
all of us are surgeons here. We're all in the business of taking care of things when they go wrong. But man, I'm telling you, what a great opportunity to just completely wipe a disease off the face of the earth, and yet we're not making any progress.
I would back in '97 is when I moved to Florida. So a few years later, I'm in Disney World, strolling my daughter around, and I start noticing the physiques on the kids in Disney. And I'm like, what in the world is going on? You talk about type 2 diabetes. It was it was almost like being in a clinic, just seeing. And I started thinking, man, when I was growing up, I had my high school class, we had over 420 some odd kids. And I don't think there were 2 kids who were really technically overweight. They might've been considered husky, even guys that played football. Nobody was like morbidly obese. And I'm looking at these 12-year-old kids, let's say around that age or younger. And it's like, good Lord, what is happening here? This is really a scary thing. And I think now here we are 20 some odd years later. In my practice, I was seeing younger people coming in. Young people already had a leg amputated, maybe in their 20s, early 30s, on dialysis. And so, yeah, Randy, to your point, it's scary. And David, I'm sure out there in California, where you're in SoCal,
we're victims. We're victims of our own abundance. Back in the days when I grew up, the proportion of income that people had to spend on food was dramatically greater than it is now. Food is cheap, it's abundant, and it's really easy to get overweight, and
it's processed.
And yet we don't. We never hear a conversation about. We hear it, but we ignore the conversations about self-control and how to take care of yourself.
Well, to your point, it's processed. An apple back in the 50s is like, so big. An apple now, because it's been pumped full of all of these chemicals and things like that, it's huge. And then that stretches our expectations as to what a serving is. I mean, it's ridiculous.
It absolutely does.
That's perfect. But let's not even take it, Rhonda. Let's not take it back just 50 years or 20 years or let's take it back. Not to go off on a tangent, I assure you this is not, but let's go back about 12,000 years, right? And that's when, give or take, depending on where we were in the, that we stopped being, it was complicated, but we eased in to stop being as much in the hunter-gatherers as a species, and a bit more agrarian. But that's where the first kind of hybrid or agrarian peoples, set up shop, whether it was in the steppe or whether it was in the Fertile Crescent or wherever it was in various parts of the world. But, before that, if you think about it, the way that we would die as a species, and this is only, I know 12,000 years is a lot, but in the arc of time, it's not.
Right.
And before that, the way we would die would be we would die with some accident, right? We'd get speared by something or eaten by something. So it was what one would call disaster, right? After that, it was we'd get closer, circled the wagons, as it were, in these villages, and as we got closer, we started dying of what? Disease. So disaster, disease, and figure out right now we're in a pandemic. But 2009, very recently, was the first year in the history of us since we became agrarian. 2009 was the first year that more of us started dying, not from disaster or disease, but from non-infectious diseases like heart disease, cancer, diabetes, the big three. And so when you think about it, there's a wonderful kind of analogy that was put forth by folks in the UK Stem Cell Foundation. They talk about going from disaster to an era of disease to an era of decay. And now what we're dealing with are diseases of decay. And we're in the middle of a pandemic now, but at the end of the day, these pandemics are going to come and they're going to go.
That's right.
Those are unlikely to wipe us out. What might wipe us out is, as you said, Randy, this abundance, and Rhonda, you talked about it as well. But it's both a blessing and a curse. But our goal now is, in many ways, is to try to we can't disobey decay, if you will, but maybe we can delay decay. Right. And maybe we can. So that's where everything that folks are doing. And if you think about a lot of what we're doing, we're working on, a lot of it tends to be replacement parts in one way or another. We're trying to get and so that's the big idea right now as a species, kind of moving forward through the arc of time. And diabetes within those big three is, if you were an evil deity, I'm going to be quiet here in a second, by the way, FYI. But, if you were an evil deity and you were trying to sock it to humanity, you would not pick, a heart attack. You would not even pick cancer. God knows, for all of us that have had family members that have succumbed or survived, Des, and thank God, you'd pick something like diabetes because it's quiet and it's sneaky. It's silent and it's sinister. People die from quiet things, and you blame other things. And sometimes you even blame them or their constitution. Oh, he or she,
right?
But when in fact they had the genetic, or maybe in some cases the epigenetic stuff stacked against them to begin with, right? To where maybe folks are programmed to store energy for the lean times. And and all of a sudden you change things in a couple of generations, right? And totally a diet, and we're all expected to get on our friggin' Pelotons? I don't think so. Right? I think it's a lot more complicated than that.
Yeah.
But it's a big idea.
Our whole careers have been reactive. That's what medicine is.
Yes.
So what I used to do, I'd say, is plumbing. Well, And I'd say, well, what caused heart disease? Well, I said tobacco and your parents, and you can't shoot your parents, but you can.
But right, and you got it.
Well, what I was going to say is what you just said. The only thing I can say is when I look at the kids in the 20 to 40 somethings, they're exercise. God, I'm talking about my son, and he hurt his calf or something. He's 41, one of them. And I said, well, Lee, you're running. I didn't even know how to run when I was 20. That wasn't even that was nowhere on my flight path.
Yeah.
I was nutrition to me came from grain, but it wasn't the kind you ate. And, it was different. So I'm sitting there going, now, the thing I think is interesting going forward is I'm waiting for, and I don't know, this is more ethical. When we get this ability in the insurance industry, to genetically map and say to Rick, who's 18, well, you've got a 78% chance of pancreatic cancer, I'm not sure I want to know all that, or if all of a sudden we're all living to 150, we have a population problem. I mean, we'll all be gone. I'll have dirt on my head, so it won't matter. But I think that's the next thing that's going to come in the next, that's, and how are you going to manage that? I don't know.
Do I agree? But again, in medicine, right? What are we good at? You mentioned it so well, especially after conflicts. But so we're good at trauma, right? So big advances in trauma after conflicts, but these things are emergencies, right? Someone's bleeding. Stop it, right? Put your finger on it, stop it. Or someone just got, knocked in the head, or someone just got this and that. These are emergencies. And just like a species, we're really good at responding, whoa, what's that sound? Fight or flight. Mm-hmm. We are not good. I think we can agree collectively on planning or on long-term stuff, right? Mm-hmm. When things change slowly over years or decades or eons. Mm-hmm. But I guess we're better than most species at it. But I don't think any species was really made to plan like we need to plan, because of what kind of a success that I'm not articulating this very well, but because of what kind of success we've already had up to the point mm-hmm. that we're having the Doctor's Lounge chat virtually during a pandemic.
I think that's fairly profound what you just pointed out. Yeah. And that is that we are the only species that's capable of planning our future. And look what a great job we've done, right?
In some ways.
For us and all the other species.
Outlander, and you got time travel.
That's right.
Somebody comes up with that, Orson Welles time travel thing, well then all bets
are going to the Stones.
It's Back to the Future.
Yep, 7 stones. I'm going.
So I want to just kind of draw this in a little bit now too, because so what we've seen. So back in '96, I was in my first year of training, and I remember one of my co-residents talking to.
Oh, by the way, Desbell, have we gone too far afield for you?
No, this is Dave. No, not at all. This is how it rolls. We could be talking about baseball 2 minutes from now. So
I would like that very, very much.
So would I.
Yeah, the whole series. That's right. He's living there.
That's right.
Sorry, I went off Dodgers and Los Lakers. This is the greatest ever. I mean, it could be the apocalypse, but we got Lakers and the Dodgers. First time, 32 years.
I know.
First time in 32 years. God bless you.
Interestingly, that's 32, and that was Magic's number, who also happens to be one of the owners.
Co-owners.
Nice.
Beautiful thing. But so what we've talked about a lot of stuff in the dynamics of diabetes and what's happened, and our ability to plan, research. All these things have led to improvements in how we treat diabetes and really limb preservation. We've had incredible breakthroughs over the past, let's say, 15 years, even 20 years, to kind of stretch it out. At the same time now, while we were seeing a little drop for a while in the amputation rate for lower extremities, it's going back up again. And what I started saying, we had 16 million people with diabetes back in 1996, and we're now up to about 34 million. And so where does this all end? I mean, how do we, I just see that we don't even have the proper number of providers to manage all this. We're doing our part.
We got to go back to nutrition.
So nutrition, I absolutely agree, is part of it. But this is a worldwide phenomenon too.
It is.
So it's not just the eating habits here in the U.S. It's how we prepare food, how it's processed. But I just kind of want to throw it. It's like, are we spinning our wheels? Do you ever have days where you just throw up your hands and say, you know what? To me, this battle is too important. But how do we start driving this public awareness that has, everybody's wearing masks now. Well, how do we get people to maybe keep those masks on, maybe avoid a few extra meals here and there?
What is the incidence of diabetes?
Hey, there's a great idea.
What is the incidence of diabetes, though, in other cultures, in Asia, India, China? Is it variable? You guys?
Yeah. So right now, if you look around the world with the best available data, one of my great mentors, Andrew Bolton's actually the president right now of the International Diabetes Federation, and may God have mercy on his soul. Working with that organization, it's like working with the UN, but I think maybe harder. But the IDF, not the Israeli Defense Force, but the International Diabetes Federation put out a diabetes atlas every year, every couple of years. It's really outstanding, and I've had the pleasure of working with some of the folks on it in the past. And the best available data right now shows that we got about, give or take, about 500 million folks with diabetes right now, and there's likely more than this, but give or take about 500 million right now. People with diabetes around the world. There's about there's really no culture that has a low incidence of diabetes anymore. I mean, people used to say, well, China doesn't. Well, now, God knows, there are, I think, 140 million people in China, 138, 140 with diabetes right now. In South Asia, meaning specifically in India, especially, there's about 70 or 80 million, give or take. Of course, the Middle East and North Africa is tremendously affected, but most of Europe is. It used to be that the Finnish country, or I should say the Scandinavian countries, were not affected at all. They're definitely affected. Type 1 is, even more than type 2, but every place is affected. And there's really basically just about no place in the world where the problem does not exist now, where it's not increasing. But just as you said, Rick, you talk about, I think in medical training in general, we'd like to think that we got trained with nutrition, but do we really know what we're talking about? And a lot of times we say, oh yeah, just get a friggin' nutrition consult, or just, feed them some Juven or something, whatever, write the script. Right. One of the most profound things we've done, Rick, in our little clinic, in our kind of our one sort of flagship clinic, is we've added nutrition and dietitians into our clinic. And Maurizia is in our clinic now. She's freaking great. I was just with her yesterday, and not a patient goes by that she doesn't impact directly in the clinic. And she calls everyone and is following them. That's not just on an inpatient basis. When things are urgent and emergent, it's or an emergency. It's actually preoperatively or during healing and whatnot. And a lot of our patients they may be morbidly obese, but strangely they have protein calorie malnutrition. It's just the oddest thing, or vitamin D deficiency.
Well, I have a buddy here in North Carolina, and I said, why don't you do some prospective studies where you go ahead and give on your elective cases, go ahead and give these folks Juven, get nutritional assessments, their pre-albumins. No, because they're all PCM, they're all protein calorie malnutrition, whatever.
Absolutely.
Kwashiorkor is what we call it.
I was shocked when I would always look at the nutritional profiles and the indices of my patients who were hospitalized. Every one of them were malnourished, not enough protein, not enough albumin, yet they're, like you're saying, obese, which kind of leads me to this one little point here too. And we kind of glossed over a little bit earlier. There's a perception among many that it's our patients' faults that they're like this, and that they, they're diabetic, they lost their leg, it's their own fault because they had something to do with them, bringing this disease on and then not taking care of themselves. How do you, from all of your perspective, I want to hear everybody's, thoughts on this, because to me, this is one of those things that has really bothered me over the years, because it's out there.
I'll be happy to speak first on that. I don't think that you can look at an individual and say that this is your fault when the only thing that they're doing is practicing the lifestyle that exists everywhere around them. And
well stated, Randy.
I mean, that's
well stated.
That's just the way that we do things. And again, I hate to keep talking about the good old days, but it is a fact that when I was an elementary school child, twice a day, they sent us outside and told us to go play. Mm-hmm. And of course, that was good for us. It also kept the teachers from committing suicide. But there is this intense focus on we got to get these kids smart so that they can have these huge SAT scores and go to Harvard and all that kind of stuff. It's all we are. I think we've really undone a healthy lifestyle in a very accidental way, and I don't know how you change that. I don't mean to tell you that I have the answer, but that's what it's about. The lifestyle has changed, and we are victims of that lifestyle.
Yep. Rhonda, want to add something to this?
Yeah, actually, I've given this topic some thought, and really, what prompted it for me was a dinner out with friends. Gosh, this has been maybe 5 years or so ago. I won't name the restaurant, but their menu is about 20 pages long, and I ordered pasta.
Everybody loves Cheesecake Factory.
It's okay. It's okay, Rhonda.
I ordered pasta. It was enough to feed my entire family for a week.
Exactly.
I took it home. That was one serving. That was their portion for one serving. So, as I was thinking about this, and I was watching people around me eat the whole serving and then order cheesecake, which the slice of cheesecake is pretty much the whole cake.
Good Lord, yeah.
That's a week's worth of calories, and then what kind of activity are you putting on top of it? So from a business perspective, I'm looking at, well, how do you make it a worthwhile venture to benefit the restaurant industry so that they want to get on board to help with the medical industry to persuade and try to, create meals that are well proportioned, and we kind of bring our expectations back in as to what is an appropriate portion, and they're incentivized somehow. I don't know what that looks like, but you have to look at it from a business perspective too, because they're making money off of this supersizing and mega, and they're going to keep doing it to our detriment. That's my thought.
There's a price to pay.
Yeah. So I guess the short answer to what you said, Rhonda, is yes, I guess. But the good news as well, though, is I think there has been, I know it's hard to see stuff when you're in the middle of it, but I think there has been over especially the last decade, a small shift in the right direction. I think you're seeing fast food dramatically change because, and you know who's changing it? We're not changing it.
Oh, no.
Our kids are changing it because our kids are seeing exactly what we've just said. Randy, what Rick, what Des, and what you just said. They're seeing it in themselves, and so they're saying, you know what? There's no way I'm shoving the two all beef patty, special sauce, little cheese, pickles, onions, sesame seed bun down my throat. As good as that sounds, right? And so you're finding they're leading with their wallet. And so that's what's leading it, just like you said. And so, it sounds crazy. It sounds absolutely just tree hugging and eye rolling to some.
I'm happy to hear it's going on in California. I don't think I will live to see it in Alabama.
But I tell you, just wait,
Yeah, give it time.
Just started selling. This is not
good.
in California now. They're going to coming out now nationwide in McDonald's. Believe it or not, with a friggin' plant burger. And when I first heard it, I had they're going to call, but I had like a visceral kind of, my initial reaction was kind of negative. I said, "Oh, come on," but because I thought, is this a sign of the apocalypse? But then that was my reptilian brain. But then I let it kind of filter up top, and then I said, "Hold on, that is okay." And so you're starting to see this slowly happen. Now, maybe it's going to happen in rural Alabama, or before later than it will in maybe in New York.
One of the most popular grocery stores in the county where I live is called the Piggly Wiggly.
Yeah. Pig, of course. Right. We're in the South. Yeah. I think part of it, though, too, is, we're seeing more like, supermarkets like Whole Foods and those type places, too. And I think part of the challenge is to make it affordable and to, just make things appealing, too. Yeah. We're always on a tight crunch, it seems, for time. So, we get into that habit of not having to prepare, throw things in the microwave, et cetera.
Well, it's not just that, though, too.
I was going to say, think about the pandemic. We don't even find eating out, getting food from eating out now even fun anymore.
Yeah.
What have you been doing? You've been eating pizza. You've been eating Chinese.
Yeah.
You've been eating. You can order delivered from Cheesecake, one of the half salad, which looks like they farmed an acre to get it.
Exactly.
I mean, but it's brought to your door. Yeah. You don't even have to. It's the Amazon of eating. What do we do? I'm not doing it. I'm just calling here.
I know it's crazy. When I was a kid, we rarely ate out, and we certainly didn't go to McDonald's. It was just dinner time was at 5:30 or 6, and anyway.
Well, I have another thought with that, though, too, though. I speak from my frame of reference, which I think most of us do. But, another contributing factor, which is, again, to the malnourishment, is urban deserts. When you have, just your bodega within 5 blocks and there's not fresh food, there's nothing fresh. It's all processed. That's also contributing to it. So you have to look at other areas where people live and what's going on in their nutrition. So
Correct.
That's another big issue.
Yeah, and a dollar meal is it's pretty appealing when you're down to a couple bucks.
Yeah, very much so. And the other thing, and I'll be quiet for a minute, but as we've described this scenario, Randy and I've discussed it. It is one of the scariest films I've ever seen ever, and it is the film WALL-E. And there is a scene at the end of towards the end of the movie where my husband and I looked over our 5-year-old daughter because we took her to go see it in the theater. And we were just big saucer eyes like, oh my God, that's our future. These large individuals who have TV screens in front of them and they're being pumped full of who knows what to keep them fed and nourished. They never leave their chair. Scariest movie ever.
What's the and all I can think of is Loma Linda. So you guys get my brains and Italy and stuff. But what was the study they did?
Blue zones. Yeah. So you got So Loma is one with the Seventh-day Adventists, and I think Santorini, maybe in Greece, and maybe somewhere else, and then Okinawa.
And they've got. They drink wine and this and that, but they do, so to study those areas, maybe we need to really do more research on that.
So we got that. And the other reason that and I'm sorry for being the Pollyanna here, kind of, but there is hope here because there's little incremental change now that you're starting to see it. And it happens like always in different communities at different times. But now 5 years ago, certainly, we've been working with what people now call wearables since the 90s, since the activity monitors that exist now that are basically free. We bought things with timestamp activity back then. They were analog. It was crazy how we had to do. And that was when we went uphill in the snow twice, both ways to go to school too.
Yeah.
But no, it's really true though. In the early mid 90s, we bought these things and they cost $5,000 a piece for the really, really good ones. And we'd spend, but now, and we would dose activity like you were dosing a drug, right? Now, fast forward through the 2000s, certainly through the 2010s, and right now up until 2020, a lot of people have access on them or around them to an accelerometer and these devices, these gyroscopes or accelerometers now are counting steps and counting activity very accurately, and it's getting to the point now. And if you can't you can't manage what you can't measure, and we are seeing very real. And it's in privileged kind of communities now, but it's starting to trickle out into all kinds of places where people have a watch where they can track their activity, and people might want to be just a touch more active, just like people that you can roll your eyes at these hybrid cars, right, at a Prius. But what does it do? It gamifies fuel economy in a way. And so people want to maybe have a little bit, they used to call it hypermiling when they first got those cars. Kind of people were goofing around with other things, so they got even better gas mileage. Well, the same thing's happening now slowly with these wearables, in that we are gamifying, and you can get maybe better health economy. And
you're Billy Beaning life.
Yeah, you are. Yeah, exactly. Well, I know. God knows if you could sabermetric this stuff, which you can now. It's crazy, and you can be your own Billy Bean, right? And that is exactly what's happening. And so
it sure changed my behavior.
There you are. See,
this thing buzzes me every hour if I haven't walked enough.
It's an eye opener.
We have a grant starting right now. I'm keep looking at let me look right now. I keep looking to see when I'm going to hear from Teresa Jones at the NIH sometime, hopefully today. But we are getting a federal grant where we are giving people offloading devices and randomizing them into devices that are kind of traditional devices to protect their feet with diabetes and wounds, to heal them, and some that we lock on them, like force them right into being compliant or adherent, and then another one where we give them the same device that takes pressure off just as well, but giving them a smartwatch along with it, so that it will give them little prompts, giving them a happy or a sad face when they're wearing it or not.
Cool.
And alert them and alert their caregiver when they're wearing it and when they're not, and trying to coax them into being a little bit more, adherent to the thing. And we'll see. We'll see what happens in this.
I think, that the whole point of even whether we're taking care of our patients, we always tell them it's not a one-way street. I can't do it all for you. You're engaging the patient. And I love the idea. You said it. You're gamifying it. You're making it fun for them in a sense, or you're challenging them. We all like to compete. Against ourselves. It's a good thing.
These folks are not trying to be intentionally, as frustrated as you might get. And God knows, I'm sure it happens all the time. Like it does with us, but folks are not trying to intentionally deceive us. There's not some evil cabal.
Exactly.
Folks that are getting together, or they're not trying to. There are very real problems with executive function in some patients, with very severe complications of diabetes. Number one, with decision making. Number two, very real problems with more than half of our patients. Whether they can put on a front, but more than half of them are clinically depressed.
Oh, for sure.
And they're just totally down in the dumps.
Yep.
And they're just not going to make the same decisions that they would if they were right-headed. Number three, they're in a position to where they're not able to do what we prescribe them to do. They've got to drive. They've got to take X, Y, and Z. They're caring for their parent. All these different sorts of things. They can't see, and so we got to meet these folks again. not to wax touchy-feely, but we have to meet these folks where they are. Yeah. And when we do, it makes a difference. And you don't cast aspersions on these folks any more than they would cast aspersions on you. These are your patients and your family, basically your therapeutic spouse, right? And
that's right.
You're there for life and limb, right? For better or for worse.
Really, absolutely. Something with respect to the importance of immediate feedback, and something that I observed when I was doing wound care and our HBO patients, our hyperbaric oxygen patients. Of course, we saw them every day for at least 6 weeks and sometimes longer. We checked their blood sugars before they went into the chamber, and when they came out, we checked their, well, toward the end of my career, we were able to check their A1C every day. We told them exactly where they were, and it was just astounding. You know, they would come in with an A1C 15, 16. By the time they finished with their 30 treatments, they would be down around 7.
Wow.
And it was not a struggle. It was just that they knew what was going on. Yeah. And then what happened. We healed those ulcers, and about 12 to 18 months later, they were back with another ulcer, and the A1C was 16 again.
And
so when they lose the feedback loop, it starts to spin out of control.
Yep, it doesn't just end when that wound is healed.
Exactly.
Listen, David, you've given us at least 5 different topics to talk about for a future episode. I would love, I'm sure we'd all love to have you back in the lounge at some point and just keep the discussion going.
Oh, listen, just mentioning lounge just sounds so luxuriant and resplendent, and that's spectacular. Why not?
Yeah, man. I think we need like a lounge wear for the lounge, like our MD coach's lounge wear. Anyway,
we're taught she's supposed to be getting us the swag.
I know.
That's right.
There we go.
I'm supposed to have dress swag, like whatever.
So listen, we got to wrap it up because David, I know you have a lot going on today. But do you have anything you'd like to add? One last point. Anything you're doing with salsa, anything that's going on at Keck, anything, on the home front, anything you just want to throw out there until next time?
Well, I will say, and I think you know this, Des, that we've just now started, and God knows you guys are all very welcome. You, definitely, Des, to try to bring different physicians, surgeons, therapists, nurses, others, together to try to create a specialty or really to support what now has become a specialty kind of in limb preservation. We've just formed something called the American Limb Preservation Society, or ALPS. And it already has core support from, on the vascular surgery side, on the diabetes side, on the infectious diseases side, and of course on the podiatry side. But it's really exciting. And I would just tell you all, everyone can go participate there, because I have a sneaking suspicion we're going to be doing a lot of efforts with Save a Limb, Save a Life on the advocacy side, all the way to all the other organizations. But it's really to be an interdisciplinary bridge and bring people together. Yeah, you can go, what is it called? I think it's Limb Preservation Society. If you can type all that in, limbpreservationsociety.org.
That's fantastic. Our work is never done, and we've got a lot more to do, but it's always such a pleasure and so much fun having guys like you as part of all this, and getting to work with you, and obviously with Randy and Rick over the years too. We really are very fortunate and blessed that we had this calling, and so onward and upward. Keep the faith, man. Keep doing all the great work you're doing, and listen, I just want to thank everybody for being part of the latest episode of Inside the Doctor's Lounge. Again, we had a blast today. It started talking about, our discussion was originally about diabetes, but as you can tell, it went all over the place, which that's what happens inside a real doctor's lounge. So until next time, I want to remind you, please check out Randy Cook's outstanding podcast, Prescription for Success. You can actually hear Dr. Armstrong's discussion there on one of the archive shows.
It's a good one.
Yes, it is.
Please continue to check out mdcoaches.com and our site now on YouTube, Inside the Doctor's Lounge, as well as our new website, also Inside the Doctor's Lounge. So it's been a blast. Anybody else have anything to add before we call it a day?
Sounds great.
If not, on that screen, what, Rick? What do you got?
I'm always doing
right.
the advertising.
Oh, yeah, look at that. See?
I'm the promotional guy.
Oh, see, I don't have one.
See, you
We're not
need
shy.
one. There you
We're
go.
not shy.
You guys are wrong. I don't know the secret handshake or have the secret coffee mug.
Well,
I got a
Christmas is
coffee
around
mug
the corner.
you're going to have to go through initiation first.
Yeah.
I look forward.
It's part of it.
As long as there's no corporal punishment, there's not like a blanket party or anything like that. I'm good.
Yeah. We usually shave the head, but we'll let you off.
No goats. All right.
No, Tanya does that weekly.
Yeah.
All right. Well, listen, if you see on your screen there that little red button too, please subscribe to our channel. Again, Inside the Doctor's Lounge. It's always a blast. And again, just remember, we see you, we believe in you, and we're here for you. Until next time, I'm your host, Dr. Desmond Bell, for my colleagues, Randy Cook, Rick Zollander, and Rhonda Crow. It's been a great time. See you next time. This pandemic is taking a toll on so many of us. There's unlimited pain and suffering, loss of life, loss of limb, and it's just getting worse. There's no vaccine for it either. I'm not talking about COVID. I'm talking about diabetes. In our country, we've gone from 16 million people with diabetes from back when I was a beginning resident in 1996 to 34 million people in our country now, 88 million people with pre-diabetes. I mean, where does this end? We were so fortunate today to have inside the Doctor's Lounge one of the true geniuses and giants in the fight against diabetes and related complications, Dr. David Armstrong, one of my dear friends and colleagues in our fight against diabetes and limb preservation. Dr. Armstrong has contributed so much to the area. It's ridiculous to try and even encompass everything that he's meant to, not just the academic community and those who are practitioners, but to the patients out there too. So I hope you enjoy our spirited conversation today. As always, inside the Doctor's Lounge, we never know where it's going to go, where it's going to take us, but it's always interesting and it's always fun. It's always unscripted and it's certainly honest. And that's the appeal of Inside the Doctor's Lounge. It's a place where we can all come together and just really talk about whatever is on our mind. So with my co-hosts, Dr. Randy Cook, Dr. Rick Zollander, and Rhonda Crow, the CEO of MD Coaches, it's really a pleasure bringing these programs to you. You know, Inside the Doctor's Lounge is something that just really has evolved, and just like Randy's podcast, Prescription for Success, we were able to attract some incredible people as guests who can come on and share their stories with us too. So hope you enjoy it. Hope you'll subscribe to our channel. That little red button there that you see on the screen, please ring that and subscribe to us. And remember, we see you, we believe in you, and we're here for you. Until next time inside the Doctor's Lounge, I'm Dr. Desmond Bell. Take care.